And there's a lot of good colleagues like Claudia did that. If you develop, if you have an approach to overcoming the obstacles, you have to develop a change proposal. That means crucial elements to be defined based on evidence and consensus and so on. You have to identify the obstacles to change. And this is very, very important. I want to focus on dissemination and adoption. And with the process of implementation, new obstacles might come up, and this is very important that you get them and change behavior then. Links of interventions to obstacles and develop a plan, carry out a plan, and evaluate the progress. And I want to show you, this is in 2010. We asked our staff, what do they know about the dissemination of knowledge, and then we asked the anesthesiologists in Germany and the surgeons in Germany and the nurses. And the average number is quite the same, and as you can see here, 41% after 4 to 5 years know, and 90% were anesthesiologists, but the other groups, 40–30%. So this is important. If you want to change something on the peripheral wards, they need to know. Then the second point is adoption. That means how does the teamwork function? And you look on the recommendations on pre-medications documents, you find that the new guideline was implemented as it was in the survey on the German society. It was only implemented in 50%. 45% eased that. That means having up to 8 hours fasting periods. And 1% said, and 1% on the pre-medication document said nothing after midnight. Remembered by the patients, and this is a difference, there's only 22% implementation. And 46% was said that they are not allowed to eat after midnight. To drink after midnight, sorry. And looking on the staff who, in the teamwork, you can see that 75% of the anesthetists said they have implemented the new rules. 90% of the surgeons, 15% of the nurse anesthesists, and 15% of the nurse surgeons. And the yellow ones, well, this might be also okay within the 8-hour thing, but the red ones, I think these patients are really having that dehydration. And usually it's 15 hours if you look on the main and the median time until patients go to surgery. Looking on the fluids, what is the relevance from the point of the staff view? You see the relevance from on patients' well-being. Well, it was considered 22%, 33% likely. That means the staff means half of the patients have profited from that. Patients at increased risks, that's not the major issue, I think. Despite something, they have a problem with increased risks, and the staff flexibility is reduced. That's something we would have considered. This is not the case, really. So I think this is complicated, some psychology behind that, and this is something you have to check for your hospital. Remembering from the patient's view, before the guidelines, it was a 15-hour, no, this is wrong, this is solids and this is fluids. And for the solids, it hasn't changed much, but for the fluids, it went down at least from 12 to 7.5 hours. So it's important that despite these obstacles to change, things have changed, and this is good. And aspirations, considering that, that's from these institutes participating and looking on this, the incidence of aspirations, looking on all of these general anesthesias was 2.6% compared to 3.3% with traditional care. So these guidelines haven't changed the incidence of aspirations. Most of our aspirations are seen in too awake patients to get intubated. So the efficacy, the effect of a new policy on operating room utilization. There were no more delays, no more aspiration, no more research, a better situation with rapid sequencer. So I think there was no increase in cancellations or delays of surgical procedures. This is very important if you look at this, because most of the situations where you have questions from your surgical colleagues on this issue. And I want to give you a new situation with these fluid things, and we did that in a retrospective study, and you can't do it prospectively, but the point is, from a retrospective point of view, if you look on postoperative delirium, and that is not monitored in most of the recovery rooms all over Europe yet, despite the fact that many of our, particularly elderly patients, already have delirium according to the guidelines in the recovery room. And if you look on these early situations, that means in the recovery room, and many of the studies are delayed, so you can't find out what the real relevance is, and time is fraying in this situation, it's very important that the preoperative fluid fasting and this intraoperative analgesia has a major impact of postoperative delirium in the recovery room. And there was not a problem with surgical duration or kind of surgery or any kind of anesthesia or solid fasting or gender or age in the recovery room, early in the recovery room. It was only the analgesia and fluid fasting problem. Later on, if you look on the first day and the early postoperative delirium and the hospital length of stay, you will find out that this effect is not seen any longer. And then, however, the delirium at the day 1 after surgery was the major impact. And this is very important looking on these elderly patients, because they have cognitive dysfunction, go to rehabilitation centers and don't go home anymore. And are now patients in some high surgical risk groups, 30% don't go home after surgery anymore. And age then is important. It was not important in the recovery room if you treat early. And here also, I think this is something that would come to the next talk. The preoperative solid fasting gets more important in this situation. And fluid fasting, this effect is gone after you look on a longer time. But if you look very early, it will help to change behavior. Surgical duration was then also an issue that was not in the recovery room. So it's very important that you implement activities and to get that shorter preoperative fasting. And this is not easy, but it's very good for the patient safety and for the quality of your work, because you don't see that if you only look at that patient in the recovery room, but surgeons see afterwards, or even after months. If you have a 3 months higher mortality in these patients, but it's only retrospective, was not very good standardized, but it's coming up with this data. So I'm coming to the next point, and also think it's very important that it's very traditional. Drinking and eating is a very traditional thing. And I was at the Rijksmuseum here, and there's an exhibition on ik fast. It means I'm fasting. I've learned that. And the point is that this is very, very important, that people have different attitudes there, even patients, and they say, okay, I'm an excellent patient, I haven't drank and I haven't eaten and all that. That's something this is also an attitude you have to overcome, and it's very important that you consider that and put that into your implementation protocol. And I'm very interested what Bas will tell us for the next talk, and thank you very much for